Okay, take 15 seconds to pause this video, read the question, and then we'll go through the answer together. So the first thing I like to do when I approach these longer questions is to look at the last sentence and see what they're asking me. Sometimes it'll be just a simple question about a medication or about a mechanism of action that won't actually require you to make a diagnosis or deal with all this nonsense up here. In this case, it's definitely going to require us to have a diagnosis to know what the likely urinary findings are. So darn it, who wrote this question? We're going to have to go back into it and make the diagnosis. But when I make diagnoses like this and I'm given imaging, the first thing I always like to do is review the imaging, because a lot of times the answer will be staring at you right in the face in a picture on the slide. And in this case, we have a chest x-ray. And the way that I like to go through a chest x-ray is going through this A, B, C, D, E criteria. So first I look at the airway, the trachea appears midline, it appears patent, bones, I don't see any fractures here. Cardiac, the cardiac silhouette doesn't seem enlarged, it's under half the size of the entire chest cavity. The diaphragm, I look at the costodiaphragmatic angles, they're very pointy. I don't see any fluid here to suggest a hydrothorax or anything like that. I don't see any free air poking above the diaphragm, like a sliding hiatal hernia, or free air under the diaphragm to suggest a bowel rupture. And then we look at everything else. So now we look at our lungs. We make sure that we don't see any pneumothoraces. I don't see any in this diagram. And then finally, we'll get to the thing that's been staring you in the face probably the entire time I've been reading this x-ray. And you can see right here, we have this giant mass in the lung. And this mass in the lung, coupled with other aspects of the history, like a 20-pack year smoking history, as well as intractable coughing resulting in hemoptysis, should be kind of alerting your spidey senses that we are dealing with a picture of lung cancer. So we have this picture of lung cancer, but there's also some other symptoms here that aren't directly explained by this woman's cancer. So these leg cramps that are waking her up at night, frequent afternoon headaches, and a seizure. These are not symptoms that would classically present in a straightforward presentation of lung cancer, but they are symptoms that could be suggestive of hyponatremia. In the setting of lung cancer and hyponatremia, the thing that should be most on your mind is the association between small cell lung cancer and SIADH. So this is a great picture for SIADH. Now, I think there's a couple ways you could enter this question, though, and you may not have picked up the lung cancer first. You may have gone into this question and read the leg cramps, the afternoon headaches, really thought about those seizures, and thought about what could be causing them, and gone first into this question thinking about hyponatremia. And if we did that, and we approached this question thinking about what could be causing this patient's hyponatremia, there's actually a couple suspects. So first we had our lung cancer, right? This patient has a picture of lung cancer that could cause hyponatremia. But we also have the fact that she is on lisinopril, which is an ACE inhibitor, which could be another cause of hyponatremia. So to differentiate between these two causes, then we would have to go back to our hyponatremia chart. And zooming into our chart down here, we can see that the two causes of this patient's hyponatremia that we have to consider to answer this question are ACE inhibitors, because we do have to consider whether her lisinopril could be causing this hyponatremia, as well as SIADH with that cancer association. But to decide between these two causes that are both present in the question stem and could cause this patient's hyponatremia, the key differentiating factor here, as we can see on our chart, is going to be the volume status. So if we had an ACE inhibitor causing her hyponatremia, we would have a hypovolemic hyponatremia. And if we had SIADH causing her hyponatremia, she would be euvolemic. Now the question stem gives you a clue here. It tells you that her JVP at 45 degrees is 7. And JVP at 45 degrees of 7 is pretty normal. That is not a good indication that we have a hypovolemia. So I would say that our patient is in this euvolemic category. And that is how I would differentiate between these two causes of her hyponatremia and ensure that we get this question right. Once we have settled on the fact that SIADH is going to be the most likely cause of this patient's hyponatremia, we can zoom over to this chart over here to help us answer the rest of the question. The question asked us about the diagnostic urinary findings, and it gave us urine osmolality, urine sodium, and serum osmolality. Remember that urine osmolality is a great proxy lab for seeing if we have ADH in circulation. Urine sodium is a great proxy to see if we have RAS activated or inactivated. And then serum osmolality is just going to be if we have a hypotonic, hypertonic, or isotonic hyponatremia. We already know that because both of the diagnoses we're considering were in that hypotonic hyponatremia category, that our serum osmolality should be low because this is a hypotonic hyponatremia. But that still leaves us with what is going on with our urine osmolality and our urine sodium. Well, if we have SIADH, the syndrome of inappropriate antidiuretic hormone release, then we are going to have increased antidiuretic hormone present in our circulation. When we have increased antidiuretic hormone, that means that we are pulling more water out of our urine. Our urine is becoming more concentrated, and that is why our urine osmolality is going to increase. Higher osmolality equals higher concentration. Second, we have our urine sodium. So we're talking about what's going on with our RAS. And remember when I talked about kind of the RAS escape with SIADH in different videos? In SIADH, one of the reasons that we have a euvolemic hyponatremia is because RAS is still acting appropriately to manage our volume status. So even though antidiuretic hormone's gone off the deep end and is saving all this water, our RAS is kind of compensating for this, and our RAS is actually inactivated. So our RAS is inactivated so we can waste some of that sodium. Wasting that sodium means there's a lot of sodium in our urine. So our urine sodium is going to be increased because our RAS is inactive. And if we look over here on our chart, you can see that SIADH is in this first box with our ADH present in urine osmolality over 100. So that checks out. Our urine osmolality should be increased. And then our RAS system is off and urine sodium should be greater than 30. Yep, our RAS system is off, so our urine sodium was also increased. So this table is a great way for you to help verify if what you're thinking through with the pathophysiology is actually was checking out with these lab values. Now that we have this straight in our mind, we can go back and evaluate our answer choices, and we see that right here, choice E is the only one that has our increased urine sodium, so that checks out right down here, increased urine sodium. We also have our increased urine osmolality, and then we have a decreased serum osmolality. And that's going to be the correct answer here, right? Because that checks out with all of the pathophysiology that we have just run through. Let's quickly talk through the other answers and see what kind of pathology we would see them in. So if we had an increased serum osmolality, remember, if we have an increased serum osmolality, then we have a hypertonic hyponatremia. There's only a couple things that would cause that. Things like adding mannitol to your blood. That might happen if you get IVIG. Things like adding radiocontrast dyes or radiocontrast agents to your blood. It doesn't make super sense that your RAS would be off and that your ADH would also be activated in this scenario. So option A does not look like a great option to explain what's going on in our patient's pathology. Option B, we have a decreased serum osmolality, so we're going to have a hypotonic hyponatremia. And then our urine sodium is going to be low, so our RAS is going to be activated. And there's only a couple things that really cause a low urine sodium and a low serum osmolality in terms of hyponatremia. And that's going to be like vomiting, dehydration, and water loss. The urine osmolality won't necessarily be low in these cases, so this is kind of an incongruent picture here. And so option B also would not be a great explanation for what our patient has. Next, we have a decreased urine sodium, an increased urine osmolality, and a decreased serum osmolality. This would be a better picture for that dehydration, nausea, vomiting cause of hyponatremia because our RAS system is definitely on and we have this increased urine osmolality, so our antidiuretic hormone is also going to be very present. This is actually what happens if you had severe volume loss through vomiting or dehydration, because since you've had such severe volume loss, your RAS is trying to overcompensate, your antidiuretic hormone is trying to hold on to all the water it can since you've lost so much water. You're hanging on to both water and salt. And this is a very accurate picture of what is happening in the case of vomiting or dehydration losses. It's just not what's happening for our patient. So this would also not be the correct answer. Looking at option D, where we have a decreased urine sodium, we have an increased urine osmolality and an increased serum osmolality. So this increased serum osmolality again should key you in that this is not the right answer because this would be a hypertonic hyponatremia, so not a great fit, and we can cross that one off immediately. Option E was our correct answer. Then option F, again, is another one of those hypertonic hyponatremias, and again, this is going to be an incorrect answer. I hope this video is helpful, and I'll see you next time.